All right, so we talked about that. So EHR concept overview. So EHR represents the integration of healthcare data from a collection of systems. So we have clinical information systems, so computerized provider order entry. So when this first came out, people were like, okay, this is enough. We're using CPOE so we can at least understand the handwriting of one another when we put orders in. Great. So then when they started developing these clinical information systems, we use CPOE, clinical decision support system, clinical documentation systems that are used throughout healthcare and others. So in healthcare analytics, analytics is the discovery and communication of meaningful patterns and data. So you're like, oh my God, that sounds so boring, but it's so important and it's actually really cool as long as you don't have to do all the math yourself, right? So when we look at things like patterns of the flu, patterns of infant mortality, patterns of infection rate, this is healthcare analytics, and it's the simultaneous application of statistics, computer applications, and operation research. Analytic finding help healthcare professionals make more effective and efficient decisions in healthcare. So here are some examples. High-cost medication prescription patterns among primary care providers. So brand name drugs versus generic names. Which you might think, okay, why do we need to know that? But it is helpful to know those things. Top 3 reasons for hospital readmission within 30 days after discharge. Why do we want to know those things? Because we want to prevent hospital readmission on both ends, from the primary care setting and the hospital setting. A hospital gets dinged when a patient gets readmitted. A primary care provider gets dinged when they get readmitted. So what are things that we can do to prevent that? Well, we need to know what the problem is first. So major standards. The purpose of standardized terminologies in healthcare informatics. So they support clinical decisions making and the evaluation of process and outcomes of care, and then to meet the need for valid, comparable data that can be used across information system application. So that's when they came to the ICD-9 and ICD-10 codes. And so some of you might be like, oh my gosh, no, don't talk to me about this. Don't talk to me about ICD-9 and 10. But this is how we code medical disease classifications. So the WHO Collaborating Center for Classification of Diseases for North America. ICD-9 were the medical disease classifications used in the US for billing. And then by October 2015, all healthcare services that receive Medicare and Medicaid reimbursement had to start submitting ICD-10 codes, which are pretty similar. And they're just really specific. So you can't put, like you have to admit or put really specific causes to why you're doing things. So if you're giving someone blood, you can't just put it under hospital admission. You have to put the reason, anemia. And not just anemia, what type of anemia, and what caused the anemia. And I know that seems like nitpicky, but also later on, when you're doing all this research and you're pulling all this data or you're trying to follow up on this patient, those codes can be helpful. So CPT, current procedural terminology, those are codes developed by the AMA and adopted by CMS and most insurance companies for reimbursement codes. So a CPT code would pertain to like your level of service with the patient, if you inserted an IV so that you can get reimbursed properly for that, or some sort of procedure. RX norm, this was developed by the NLM, the National Library of Medicine, to be a standard for representing drug information in EHRs so that it's standard across the board. And then there's something called SNOMED CT, which you might it sounds crazy, but systematic nomenclature of medicine clinical terms. So this is developed by the International Health Terminology Standard, and it's to be used in EHR for data entry and retrieval. And and nomenclature is the breakdown of certain terminology. So when you say things like tendinitis or golfer's elbow, that is broken down within the SNOMED CT. So you can't use slang or maybe a term for something that isn't real, like crumping. That's not in the SNOMED CT. But we all know what crumping means, right? Like someone's crashing. Or like my husband likes to say, dancing. He is not in medicine. So major standards: logical observation, identifiers, names, and codes. This was developed by the Regent Stripe Institute and provides a standard set of universal names and codes for identifying individual laboratory and clinical results. So if you want to check to see if someone got an ANA, which is an anti-nucleic antibody testing for some sort of inflammatory response, there are certain codes for identifying that lab so that you can identify it when you look into someone else's records. And the same goes with clinical results. The ANA recognized 12 standardized languages for nursing. NANDA is the big one. That's the one I'm sure, NANDA and NIC. So remember NANDA, NIC, and NOC. And that talks about recognized nursing diagnoses and nursing language that we use. And again, this is just really important across the board because when you're writing that stuff, you might get irritated, but it is helpful when you're actually getting the information. So the Health Information Exchange, HIE. So this is electronic sharing of health-related information among organizations. Provisions of services to enable the electronic sharing of health-related information. The importance of HIE, so reduce duplication of services and operational costs, and governs and manages the data exchange process. And we're still working on it because there are different EHRs that don't interface. And that is the goal with HIE, for that to happen at some point. But it is nice when you somebody comes in and they've been to 6 different doctors because they're having abdominal pain, and your thought is to get an abdominal CT, but they already got one. So you can look at it so that you can rule in or rule out differential diagnoses and move on. The same, so in nursing, you think, why is this important to me? I'm not a provider, but it is important to you as a nurse, right? If you're looking at somebody's past information exchange to figure out where they are in their healthcare journey so you can help make those recommendations. So interoperability versus HIE. So interoperability is the ability of 2 or more systems to exchange and use the information that's been exchanged. HIE is just the ability for you to electronically share information. They're not the same. So exchange of information is necessary for interoperability, but interoperability isn't necessarily necessary for exchange. But interoperability, you're allowed to use that information clinically and also operate within another's EHR, like send messages and make recommendations. So trends in healthcare informatics talk about meaningful use, e-health, patient portal, big data, and patient-centered medical home. All right, so meaningful use application. And therefore the general who understands war is the controller of his people's fate and the guarantor of the security of the nation. All right, meaningful use history. So the Institute of Medicine. So here's the problem. To err is human. Building a safer health system. You might be like, no, don't make me read this again. We just talked about this in quality and safety. But guess what? To Err is Human was a really important book that came out, and it made us all realize that we are a broken system because it is run by humans, and we need to look at our processes and conditions that lead to make mistakes or fail to prevent them so that we can prevent mistakes, right? So the Institute of Medicine talked about the care system. Okay, so crossing the quality chasm. So we have support, payment, and regulatory environment. So we talk about CMS, organizations that facilitate the work of patient care-centered teams, high-performing patient-centered teams, and we look at these outcomes. They're safe, effective, efficient, personalized, timely, and equitable. So we need to redesign imperatives, and there are 6 challenges. Re-engineered care process. So what care process can we re-engineer to create this kind of high-functioning system? Effective use of information technologies. How are we using all of our information technology to the fullest so that we can provide better care? Knowledge and skills management, development of an effective team, that's huge. Communication, the old way teams were used in healthcare are going out the window. and then coordination of care across patient condition services and sites of care over time. So we ran out of time for this week on meaningful use, so it's going to continue on to next week.